Welcome to Rebooting the Brain, a podcast where conversations move beyond medicine to the journeys and experiences that shape those who heal. In this episode, Dr. Sharan Srinivasan and Dr. Prathiba Sharan are joined by their friend, Dr. Vinayak Belamkar. Their friendship has carried them across continents and skies, including a memorable flight over Chicago where Dr. Vinayak himself took the controls and flew them around the city. For him, love of flying began much earlier, as a schoolboy visiting the Aerospace Center at Jackroad. He discovered the world of aviation, a spark that would stay with him for life. Years later, he would turn that spark into real flight hours, training, renting planes, and building the proficiency every pilot earns through practice and patience. But just as flying requires discipline and focus, so does his true calling in medicine, helping people live with and overcome chronic pain. Dr. Vinayak Belamkar has dedicated his career to understanding pain that lingers beyond the ordinary. Pain that does not fade away in weeks or months, but stays, reshaping how people live and function. His work spans migraines, fibromyalgia, nerve-related pain, and complex conditions where patients often feel unseen. With compassion, science, and advanced interventions, he helps restore dignity and quality of life to those who suffer in silence. In this episode, Dr. Sharan, Dr. Prathiba sit down with Dr. Vinayak to explore not just what pain is, but how it can be managed, how patients can find hope, and how medicine continues to evolve in its approach to one of the most difficult human challenges. This is Rebooting the Brain, and this episode is about living with, understanding, and overcoming chronic pain with Dr. Vinayak Belamkar.
So my first time when I got into the flight, I'm thinking small flight, what's going to happen if it breaks down and something happens, what if I die and all of those things. Then I said, see, this guy is a doctor, successful guy. If he's trusting his own life in his own hands, I don't think I should worry about that. If he goes down, we also go down. Jai Bajrang Bali Ata and this and that, and I waited, I didn't worry that. Then I saw how meticulous he was. He's looking at the numbers. He's talking to the, the control station. He's doing it the right way. Then I said, okay, this guy knows the stuff. I'm going to sit and enjoy the ride at the end of the day. And I tell you, even till now, I don't think that's going to change.
Very true.
That was probably one of the best experiences we had, probably apart from going to Antarctica for a cruise. It's right up there for us. One, the element of surprise. We didn't expect this to do. And, you took us around. We saw the lake. And after that, somebody said, I saw it from top. I don't want to see it from... we went to that level. Seeing it from the ground is of no fun now because you showed it from the air and things like that.
Jnananandamayam Devam Nirmala Spatika Krutim Adharam Sarva Vidyanam Hayagrivam Upasmahe Adharam Sarva Vidyanam Hayagriva Upasmahe Hayagriva Upasmahe.
Rebooting the Brain, powered by PRS Neurosciences.
Namaste, everybody.
Namaste.
Asato ma satgamaya
Tamaso ma jyotirgamaya Mrityorma amritam gamaya. Om Shanti Shanti Shanti.
Hi everybody, I'm Dr. Sharan Srinivasan, a functional neurosurgeon from Bengaluru, India. Welcome to our podcast today, and we have an incredible guest with us who's going to talk about pain. Pain. It's very painful. Before we go to him, I want to use the usual housekeeping rules. Please subscribe to our channel. Please press the bell icon. Share these videos and many others that are there on our channel. You never know which patient is going to get help to get the help for themselves or the family. Press the bell icon and definitely comment on whichever video you love, because you never know, those comments can help us to make the content more useful, to create more awareness, and somebody else in the group to get more benefit. So let me introduce to you our guest for the day, a dear friend of mine from school, Dr. Vinayak Belamkar. He's come all the way from the US. He is an intervention pain physician. He's going to tell, as the podcast goes, what all he has done. He's done some amazing things as a doctor and other things that we will talk about. Vinayak, welcome to our show.
Welcome,
Vinayak.
My pleasure. Thanks.
So now, Dr. Prathiba, you have anything to tell our guests?
Yeah, I mean, before we go into actual
Pain.
pain as pain, I've had this incredible experience when we traveled to US that, you flew a aircraft and took us around Chicago. I mean, that is really something unbelievable till today, right? So what actually made you I have this passion of cooking. Apart from being a doctor, I love artwork and stuff like that. So was this a hobby? Why did you take a license of a pilot?
Well, it's since my childhood, I've always been interested in flying. I always looked at the planes, and it was interesting. But I did in ninth grade, ninth standard, when I was at Pune, I did a camp, and they took us to. I was in NCC.
NCC, yeah.
And we went to camp, and one of the things they did was they took us to Jakkur here,
I remember that.
and they flew us in a little glider.
Oh, they flew there, huh?
Yeah.
Oh, I didn't know that. Okay.
So we're all kids, we are standing. And just imagine all our clothes are all misfitted. One has loose pants, tight pants. The shoes are big. The topi's all. And then this squadron leader, I still remember his name. I don't know. I can mention his name.
Of course.
I think it was Nirmal Thusu, squadron leader. And he's like a movie star. I mean, he just comes in. He's got this. I think it is Ray-Ban. I didn't know what it was. Like sunglasses. His hat is shiny uniform and pressed, and he comes in and he starts flying people around, and they winch it up. It goes around one circuit and comes back and lands. So the wind started picking up. I was towards the end, and I was a little chunky back then, just like I am now. But so he said, I can't take two kids. He used to take two kids in one. So I get to go alone.
Oh,
so
some fringe benefits.
Yeah. So yeah, it turned out to be positive for that. And if he took off and the wind picked up, so he couldn't land the first time.
Oh.
And so he went around second time. So I got two circuits around
Free
the
trip.
pattern. Yeah. Then he landed, and then he said, no, this is getting too windy. I don't want to take kids. This is not
just
safe.
about made it.
So every other kid was unhappy with me because, like, you got two rounds on the thing. But that was just, the bug bit me, and I was like,
Okay.
no matter where I go, I was looking at planes and looking at planes. I never thought I would fly. I was just reading about flying and things like that. Once I went to the US, you realized you could learn. And every city I went to, I would go check out the local airport, and they would say, oh, there's some training programs and all that. But then, life happens, kids, school, work. Then finally, my wife said, yeah, go ahead and learn. You're getting too, that's all I could think about. So around 2015 or so, I started learning. So I got my, what they call private pilot license. Then I got my instrument rating, so you can fly in the clouds based on instruments. So I don't own a plane. It's just a group of people. We have a club.
Okay.
And so we rent it out and fly it. So it's been amazing experience.
Like a timeshare.
Yeah, it's a timeshare kind of thing.
Okay.
So I tell people I probably own the right wheel and the left. But it's a great release. It's so peaceful, and it just takes you out of all the problems in the world, and it's amazing.
In fact, when he told me that you were coming all the way from Indianapolis to Chicago to see us and just come meet us and go back, I thought you were flying all the way just to meet us and go back. I thought that was very sweet of you, right? To take off the time like that in a busy schedule is not very common, right? But then he said, okay, he's going to come and take us around Chicago. So I thought you're going to drive us around Chicago. I said, okay, good. We'll get to go around Chicago. And then he says, no, he's flying us. I said, means? So I actually didn't get when he said that. But then
No,
when
I
I
also didn't get the
actually,
first time.
oh, that was an experience. You want to say something
Of
about
course,
that?
I want to say. When same thing that happened to me when you said that, and I asked you actually, are you driving? How far is it by driving? You said, oh, it's 8 hours or 6 hours, something you said, but flying time is only then. I said, what is he talking? Then the damn thing sunk in me that this guy is up to something different than what I thought. I didn't know anything that this guy had anything to do with F for flying at the end of the day. And then we got in. Oh, so
It was
my
an
first time when
experience.
I got into the flight, I'm thinking small flight, what's going to happen if it breaks down and something happens? What if I die and all of those things? Then I said, see, this guy is a doctor, successful guy. If he's trusting his own life in his own hands, I don't think I should worry about that. If he goes down, we also go down. Jai Bajrang Bali Ata hai, this and that, and I went in, I didn't worry that. Then I saw how meticulous he was. He's looking at the numbers. He's talking to the, the control station. He's doing it right way. Then I said, okay, this guy knows the stuff. I'm going to sit and enjoy the ride at the end of the day. And I tell you, even till now, I don't think that's going
True,
to change.
very true.
That was probably one of the best experiences we had. Probably apart from going to Antarctica for a cruise. It's right up there for us. One, the element of surprise. We didn't expect this to do. And, you took us around. We saw the lake. And after that, somebody said, you saw, I saw it from top. I don't want to see it from, we went to that level. Seeing it from the ground is of no fun now because you showed it from the air and things like that. So it is fantastic. So thank you very much for doing that for us and having a lifelong memory.
I know.
No, it means a lot to me when you say you trust me and fly, and I take that real seriously. When people, a lot of people don't know what flying is about and what the risks are involved. So it's like I take my own family and I've tried to do that. Take the same meticulous approach to flying anybody. But and luckily that day the weather was beautiful.
I know.
It was nice.
True.
And
perfect weather you were carrying.
I wish I could say I take credit for fixing the weather, but it just turned out great. And
I know.
So.
No, actually, because see, the ones, this kind of flights I've seen in Jakur, like you were saying, but that's only for those kind of flights.
Yeah.
Right.
No, you made us take off from a commercial, airport, and we had those big aircrafts in front of us, and we were behind them. I said, I'm also like, I'm also serious business. It's not this some small airfield and things like that. So that was amazing what was possible. Yeah. And I loved it. And I know how expensive it would be flying in the US compared to India, but I think hats off to you for keeping your passion and, really, because you have to, I think, fly for a few hours, minimum.
I think it takes practice, right?
Yeah.
I'm sure.
So you have to keep up what they call proficiency and certificates. So we have to do a medical exam every 2 years. You have to do fly with an instructor and every year or two. But I do more than that. I just so no matter what I do, I'll never be a professional like an airline pilot. So I know my limitations.
True.
And we have to train and practice. So that's the hard part.
But I'm glad you're able to take off time from your busy schedule and do what you love to do. That's really good.
No, I think so. Our global viewers have to understand that even a doctor like him in a country like US, where it's like rat race, everybody's running, he's able to take time off to follow his passion and do what it is. I think that's one of the lessons that you want to hear from here. But a guy from a middle class from Bengaluru city, gone all the way there, flying it, chasing his dream. I mean, for me, it was unreal.
Really. Actually, that brings me to the next question. What made you choose to go to US?
Well, we were young, so we used to read all these books and textbooks and do this and that, and all the textbooks came from either Europe or USA, and we felt like we're not doing. I wanted to do all these things, and I want to get my hands on everything, and felt like that would complete the next step of the progression. We read the whole Harrison's and all the surgical
Davidsons
Davidsons and
Hutchison and all the sons.
all the sons we used to read. So I thought, hey, that would be an opportunity. I should go and do things. And back in I left in '94. So India was a little different at that time.
Of course, a lot different.
True.
I think the market just opened. Others, we were still struggling.
Yeah. And so I said, yeah, we'll go see what happens. And then one thing led to the other. And you were like, the next thing you know, it's 20 years later. And your kids are grown up. And you're like, what am I doing here type thing. So.
And then you got introduced to the Bengaluru traffic again all over. We'll talk about that definitely a little later. But I think we should come to the topic of what you do, which is chronic pain. Now, doctor, people talk about pain. Everybody has pain. So what is this chronic pain? Why is this word chronic next to it? And what is that you do as a chronic pain physician?
So when you talk about pain, pretty much everybody knows what pain is. And, to put a definition on pain, I think the best definition I've ever come across is, and even that is pretty limited, it's described as an unpleasant sensory and emotional experience described in terms of or related to tissue damage or something associated with that. And that's pretty vague. And it's different for different people. And everybody experiences pain at some point in their life. So pain is ubiquitous, and we all know somebody who deals with pain or ourselves deal with pain. Chronic, just in terms of pain definition, we just say something that lasts 3 months, 6 months. There, different people use different cutoffs. In my mind, pain is something that lasts beyond its expected purpose. Say you do a surgery and you say, well, it takes some surgeries heal up in 1 week, some takes 2 months. So just because it's longer, I'd say. But if somebody is supposed to get better, you pull a tooth and it's supposed to get better tomorrow or do something, and then you're pain 1 week later, you start worrying about it. So it's all relative. And then the other ways to think about pain is, hey, what's causing it? Is it like we throw fancy terms like nociceptive and neuropathic and all that? And that helps us evaluate it and treat. But in general, pain that lasts longer and is starting to affect your life is chronic pain, in my opinion.
So can you give a little bit of a layman's definition of what is nociceptive pain, what is neuropathic pain, so that if they have a pain, they can understand what's this kind of pain and what do I do with that?
I mean, we use the terms to try and understand the mechanism of what's causing pain so we can treat it accordingly. Nociceptive, a simple example is you have arthritis in your knee and there's some inflammation, irritation, and then the nerves are being stimulated or more simpler explanation is like an appendicitis. So you got some infection going and your nerves are picking up the trauma and the tissue damage that we talked about. So that would be more nociceptive. Neuropathic is something...
Sorry to interrupt. Is nociceptive more acute or nociceptive can be chronic also?
Can be both, yeah.
Can be both.
Yeah. Okay. Neuropathic pain is where the nerves are involved in some way. And we usually think it's a disease of the nerve causing pain. A common one is like... diabetic neuropathy. People have a lot of pain in their feet usually. Another common one is the shingles pain. It's a nerve disease. So
shingles is herpes zoster.
Herpes zoster, yeah. So that's a gross, but in my practice, and as you see, it's a lot of things are mixed up. So then we try to kind of peel it apart and say, hey, for the nociceptive, we'll do this. For the neuropathic, we'll do this. But from a layperson standpoint, I don't think it makes a huge difference. But I would say understanding pain that has lasted longer than something. The reason I keep bringing that up is lasted longer than you expect it to. Because a lot of people just kind of, oh, it's my fate and I'll just deal with it. And, oh, there's nothing to be done.
Very true.
And karma and all that. And they just kind of deal with it and keep adjusting.
To put up with it.
Yeah, it's like boiling a frog. Put it in cold water slowly. Right, the temperature, you never know how much distress you're in. And a lot of times, once you treat them,
that's a great example, actually.
So I usually it's the family members who tell, man, he's not doing anything. He used to do this. He was so happy. He was so outgoing. Now he barely goes. And they just kind of adjust. So I think the pain and quality of life gets
very
connected. and the reason they should focus on that and say, hey, I'm not functioning like the way I used to, is what makes it chronic pain in my opinion.
Neuro. I think it's a great. I think it's a great opening because we have got set it up in a perspective.
Mm-hmm.
So I think I want to ask her. You know, the kind of migraines you have had. As neuroscientists, we have not seen migraine like
I
what she
know.
said. You know, my neurologist who treats us, sir, I have not seen migraine.
I've kind of been a guinea pig for
Yeah.
any new drug comes, they try it on me.
Status
Because
migrainosis. She's had
Wow.
status
it was
migrainosis, not
it
once,
was
not twice. You
unbelievable.
cannot even imagine. So why don't you share it to our global viewers what?
I mean, when you say chronic, this is chronic,
Yeah.
like, for years together. And yes, different kind of medication, different intervention, it would come under control for some time, and then some trigger takes off, and then it's back again.
Yeah.
And then it would last for a week, and that definitely affected my ADLs, my work, everything. It would affect. It would just put me off.
Yeah.
So every time there was, one episode is over, I've gone on, the prevention mode and everything. Somewhere, things are settling down. One more trigger happens, gone. So that time, all the conversations happen between the neurologists and the neurosurgeons and pain therapists, and everybody together, they'll come up with a new, some new drug in the market, new thing. This is better than that, new strategy. So I'm there to try it on. So for me, one side, I'm a doctor treating the patients who have pain. I've had enough experience treating his patients who he has referred, or pain physicians have referred, to give them relief. But on the other hand, being the patient, I really understand when somebody says it is unbearable.
Yeah.
I really understand. And when you say chronic, I understand what chronic is all about.
As a
It has
caregiver,
been.
I've seen,
Oh,
she's lying in the room inside the hospital, and somebody is pulling a trolley somewhere outside. It's
it
just,
would
I'm supposed to
irritate me.
stop it. It's, I mean,
It
it's
would
so far
irritate
away.
me.
You cannot even imagine how much you get irritated just by the sound that is going on. Put off all the
And
lights.
the typical, when you read in the textbook, you kind of read the
Yeah.
symptoms, right? Photophobia, phonophobia. I mean, these were terms when I read it in the books. But then when I actually experienced the photophobia, I would ask them to put iPad on my eyes, or, cover bedsheet on my eyes.
Yeah.
Oh, it was that bad. And like I said, little noise, they would put cotton in my ear, I could still hear something, and that would irritate me.
Yeah.
It was.
So, what do you have to say to somebody like this?
So, I mean, the chronic pain experience, and some of the chronic pain patients we see, I don't wish it on my worst enemy. I mean, it is
Absolutely.
torture.
Absolutely.
But I think you touched on a couple important things. You said how much Dr. Sharan suffered along with you.
True.
I'm sure you didn't have the headaches, but you were
Oh,
miserable
No,
too.
handling
Yeah,
me was
of
not
course.
easy
Yeah.
at all.
Yeah.
And it was not like half an hour,
Yeah.
they gave a tablet,
Yeah.
go away. No, it is days sometimes. She's walking around with the IV line with her because I don't know when the next dose is
Yeah.
required. She's in the
Yeah.
hospital doing rounds, and then you have to give one shot. It's crazy.
I used to do rounds with the IV line on. It used to, look crazy. It sounds crazy to people to hear, but then, it was desperate.
Yeah. No, it makes people desperate. I mean, I think that's one of the key components I wanted to emphasize is the emotional aspect to
Yeah.
it. So it's not just a sensory perception, is
Very
something
true.
happening. It takes you over. I mean, you know the pathways better than I do.
True.
It takes over the hippocampus, the
True.
thalamus, all the symptoms are, and you do MRIs, you CAT scans, EKGs, EEGs, nothing shows
Nothing
up,
shows up.
and it's so frustrating.
Yeah.
And
And sometimes if she was not my wife and the wife comes like this and the husband thinks she's doing a drama.
Yeah.
It's they have marital issues because of that.
True.
It's
Absolutely.
crazy. ಎಲ್ಲ ಡಾಕ್ಟ್ರೆ ಸುಮ್ಮನೆ ಮಾಡ್ತಾ ಇದಾರೆ ಏನ್ ಎಲ್ಲ ನಾರ್ಮಲ್ ಅಂತಾರೆ ಇವರೆಲ್ಲ ಸುಮ್ಮನೆ ಹೇಳ್ತಾರೆ ಮನೆ ಕೆಲಸ ಮಾಡ ಐ ಮೀನ್ ದೇ ಸೇಯಿಂಗ್ ಆಲ್ ಆಫ್ ದೋಸ್ ಥಿಂಗ್ಸ್ she doesn't want to do housework. And how do you justify? And this
Very
guy is
true.
looking at he's thinking I'm taking the wife's side, whatever. That's it.
Yeah, they get affected at
Yeah.
work. A lot of
Oh,
these
yes.
people lose their jobs,
Absolutely.
lose their ability to
Absolutely.
earn a living. So
True.
it's a huge impact.
Huge impact.
It's the iceberg phenomenon. You see only the tip, but there's a huge
Absolutely,
impact.
absolutely. People just don't understand.
yeah.
So when people come to me sometimes for counseling or something like that, when they say, you don't understand how bad the pain is, I said, trust me, I understand.
Yeah.
I absolutely understand what you go through, and I share my story with them, and then they say, "Oh, okay, so you gone through it." Then they open up and say a lot of things, especially the triggers. They don't open up, stress
Yeah.
busters, whatever they use, what they go through, they don't open up. But the moment I share my story, they get confidence. Okay, this lady knows what she's talking, so it is devastating.
No, again, the other aspect of how the healthcare system deals with chronic pain sometimes is left a lot to be said about it, because you have good resources, you have good background, you yourself are a trained
Correct.
physician, and then you can see how frustrating it is.
True.
But there are people who don't understand this. Their own family doesn't understand. They go to the physicians, and a lot of the physicians, unfortunately, in the healthcare system, there's nothing more we can do for you.
Yeah, true.
So one of the approaches I take with my patients is I explain to them, look, I may not be able to fix it, but I believe you're in pain. And I mean, not. So one of the things you said, no, you deal with pain all the time. How do you deal with it? And how do you know people is not faking and this and that? I said, people can do acting for a few minutes, for a day,
True.
but you
Absolutely.
see them over time. This is not something you can,
Correct.
there's not an actor in the world
Yeah,
who
yeah.
can keep
Keep it
going
consistent for
for
days together. Not
so
possible.
you just talk to patients, and that's the fun part of, not, I wouldn't say fun, but the challenging and the gratifying part of
True,
pain
true.
is you are part of the diagnostic process. There's no CAT scan, we use all that,
Yeah.
but that's nothing like says, oh, that is causing the disease. Just talking to the patient, just understanding, just looking him in the eye and saying, I trust you. I mean, that's a huge thing. And then they start talking
Yeah.
about, and a lot of times they leave the office saying, thank you for listening to me. I feel a lot
True.
better.
Very true.
Because somebody is listening to me.
Absolutely.
And I think that's what really drove us into going to medicine, right? That's what.
Correct. That's true.
So that's been one of the most gratifying
Yeah,
things.
that is like a nasha,
Yeah.
Actually, that's what
Yeah.
gratifies so much for us to do what we are doing.
At the end of the day, you say, "Oh, some days you're like, what am I crazy? What am I doing here?" Then other days you're like, thank God, we have this opportunity to help another fellow human being. We used to go to conferences and grand rounds on headache, and this neurologist and headache specialist give a talk, and they're like, you look at that diagnosis list, it's like 3 pages long and all kinds of things, and they had no really good treatments. So now there are two options, like we know about the Botox, the toxins that we
Yes.
use. The funny thing is, it was found by accident. They used to do
True.
Botox for cosmetic
Cosmetic
procedures, and
purposes.
something.
Yes.
Hey, by the way, my headache is gone.
Oh, really?
So
Why you
Yeah,
know
I
this
did
part?
that once, remember?
Yeah.
I did the
I know,
Botox
but I didn't know
once.
the
And
cosmetic
that's how
help.
they came into. It's not like a scientist with a PhD or Nobel Prize sat
Okay.
there and says,
He's like the Archimedes.
Botox. Yeah.
Archimedes jumped into this one and said, Eureka.
So that tells you how little we know. And like one
True.
of my professors say, half of medicine we don't know works or doesn't work.
Very
The problem is
true.
we don't know which half. So on the flip side, and the same migraine, now they're using CGRP antagonists and all that. And that was a more scientific process. They looked at, oh, there's a CGRP level size. So what I'm trying to get at is medicine works in such funny ways. And when
True.
people come in and say, this helps me, this doesn't help, I say, look, I believe you. And sometimes we don't fully understand. So having an open mind with somebody with pain, because a lot of them, they say, oh, you're crazy. What do you think that, you do this and the pain went away? That's not true. You just had to learn from the patient.
True.
True.
And that's an interesting experience.
In fact, recently, like I told you, my history on migraine goes very long back. And I've been off migraine, touch wood, for
Prophylaxis.
quite some time on prophylactic medication, and some lifestyle changes and stuff like that I've done. But somewhere last 2-3 months back, it got triggered again, and it was not the typical, like the aura and all that was not there. So I called my neurologist. I said, it's not the same migraine. It's not migraine. I told him this. It's not migraine, but it's bothering me. So should I do the same migraine treatment or should I do something else? Then he said, uh, there's something called transformed migraine. And this I heard for the first time. I said, really? I said, yeah, it changes its presentation.
Avatar.
Apparently,
Yeah.
because if it is a very chronic, very long
Yeah.
term migraine, it doesn't present the same way. And this is recent understanding that I got about the migraine, that it's migraine, but it is a transformed migraine. Unbelievable.
Since you're staying at Migraine, I just want to say one more thing. Her first time I remember was even before we met. We are medical school classmates when she was in 12th grade. She got the headache for the first time. They thought it was TB meningitis.
Yeah.
She
Wow.
went to Nimmans, they got a lumbar puncture done, everything is normal, everybody's scratching her head. And this has happened a couple of times. Both the times she was pregnant, she collapsed in the second trimester.
Wow.
I'm thinking of an aneurysm.
They thought
maybe.
CVT,
Yeah,
all those
sorts
things.
of stuff. You are running to do
I know.
MRIs.
So,
You know how it
and
goes.
now you have a background, so you know
Yeah, we
even
get
more.
worried.
You
Yeah,
get more worried.
yeah,
Yeah.
get
Otherwise,
more worried.
it's,
How many MRIs?
Yeah.
You can't even imagine what's
Oh.
going. Every time she collapses, you say, "Oh shit, what's going on?" We get an MRI done, get this done, get an angio
True.
done, and all of those things. Every time it's normal. And then and still we were trying to figure out why she's getting that, the whole thing. And then again, the same neurologist told us many years ago that severe migraine episode causes aseptic meningitis. Aseptic meningitis is some kind of inflammation of the brain fluid without infection. And she would need, of course, one dose of steroid, and then she would get better. So honestly, I've seen so many headaches, this and that we see, but I have not seen somebody needing all this masala every time she goes in. There was a list that we had to give, 6 injections at every time, it's like on package.
Yeah.
It's a migraine break package that I had to go, but I would call it, say, tuck, 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 get all of these things done.
But I'm really so glad now, no, after when I look back, I'm so glad I'm kind of out of it.
No, I think
Really.
also what I think we should emphasize is, I know sometimes it looks fruitless and there's no end in sight
Oh
and
yeah,
things like that.
I went through that.
Yeah.
I thought, why am I going through all this?
Yeah,
For
why
what?
me?
Why me? I've been doing everything right.
Yeah.
What wrong have I done? And he said, karma. Should I just give it up? Should I just let it
Yeah.
be? Should I bear that and live with it? And all these conversations.
No, I think patients should understand
Yeah.
that giving up hope is probably the last thing you should do.
Yes.
And I think
so.
there is a light at the end of the tunnel. There are solutions,
True.
but giving up and being frustrated and just giving up on life is probably the last thing you should be doing.
And I think you're like a library of pains, no?
Yeah.
I mean, why
actually.
not?
So the other pain I went through personally was herpetic pain.
Uh-huh.
I had herpes twice, once in the back, once in the mouth area.
Mhm.
It was bad. It
Yeah.
was again very, very painful. I think the back one must have been some 35 years now.
Maybe some.
I think so. I think just right in the beginning of medicine when we joined, that's when it was. And even now, if somebody pats on my back, it hurts.
Wow.
It's that bad. This many years.
Yeah.
But otherwise, I'm okay. But this one was too much. Again, reading those symptoms in the book
Yeah.
and experiencing those, you said, oh, the symptoms are actually true. It is not just said. Because when you read, I felt, really? I mean, if there is cold breeze, you drink something cold, does it really hurt? But when I experienced it, I did understand that it really hurts. It really hurts.
So what's your experience with managing patients like her?
Yeah.
What would you do differently, or what advice would you have such patients?
I mean, shingles pain is again one of the, I don't know what lottery you won, but you got all the lucky ones.
Seriously.
It's a challenge. And like vast majority of the people get better and the pain goes away, but every once in a while, whatever those virus reactivation does to the dorsal root ganglion, it really throws the whole pain system off kilter.
True.
So the hypersensitivity, the cold sensitivity can persist and last forever, but it'll keep getting better.
Yeah. No, this is gone now.
Yeah.
Thank God. Only the back thing is still there.
Sometimes, early on, what we're seeing is simple things like treating the virus better.
Earlier, I guess.
Start on antivirals, some steroids early on. From an interventional standpoint, injecting the nerve root with steroids or epidural steroids seems to help. And nowadays we have the shingles vaccine, and that seems to reduce the episodes that people get.
In spite of having zoster, you recommend the vaccine, right?
It depends. I'm not sure if they're having repeated, and as we get older, our immune system goes up. So I would talk to your primary care and maybe an immunologist, see where it fits. But in general, a lot of people think, why should I get shingles vaccine and all that? I think that's a good reason. I mean, you would not be a candidate because we are not recommended at this age.
Right.
It's usually as we get older and our immune system starts that we see this disaster. But you see one patient with shingles, I think I'm going to get my shingles vaccine as soon as I'm eligible type thing, you know. But treatment-wise, once the nerve gets irritated, in my hands, the best solution has been working on the dorsal root ganglion, either injections and some medications like gabapentin, Neurontin can help. Lidocaine patches. We have been using the capsaicin patches and all that. Yeah, but there are things we can do and reduce the pain.
I don't think whether the lidocaine patch is available. I'm not too sure.
I'm not sure about
whether-
that.
Yeah. Very
But I
nice.
think one thing in my own self, I understand the mouth one. I think the intervention was very early,
very early.
fast. I think that's why my symptoms are
Yeah.
not bothering me right now. But the back one, I think by the
She
time we
missed it, no, because she
diagnosed,
could
it was at the
see.
back.
So
So
she
I
didn't see.
had some other back pain. So
Yeah.
I didn't really, get it. So it took me longer time to actually to come to the diagnosis, to go to the doctor and figure it out. I think that delay is
Yeah.
what caused the damage.
And sometimes the rash takes a long time to show up.
True.
The pain comes first,
Possible.
and people are running around like,
And
what's happening?
when you don't get to see,
Yeah.
you miss it.
Yeah.
True.
Yeah.
So you made an important point. You are saying if the rash takes longer to come, then how you mean to you start the antiviral even before that? How is that possible? Because you have to have an evidence, no? How do you do that?
That's it's hard at that time to, but I think as a physician you want to have an open mind. Like sometimes, for example, we have heard stories of people having gallbladder surgeries because the pain was so intense. It's coming along the back to the
really?
abdominal, and they say, well, let's take your gallbladder out.
Okay.
Because what else is causing the pain? But I think as physicians we should keep our mind open and say,
I'm glad you didn't get.
yeah.
You got a gallbladder out, but not because of
that
shingles pain.
But yeah, there can be a diagnostic dilemma, there's pain and
Correct. You try to put 1 + 1, make it 22, 44, some number
Yeah.
just to make, because people also love to have a diagnosis on what's
Yeah.
going on.
True.
But yeah, it can, one, it is severe, so you want something done.
Yeah.
And two, there is no clear picture, so you start doing things. But generally within a few days, maybe a week or so, is the time frame that they get the lesion, so you see it. It's extremely rare, but I wouldn't. It's almost like they call it. You can have herpetic pain without the rash ever showing up.
Right.
But yeah, you hit the two major pains. Experience that. That's
True.
amazing. That's
If every disc that is there bulge in the MRI scan we remove, we'll all become billionaires.
Yeah.
What made you make that statement?
I mean, and there have been studies done where people just do MRIs on just normal people. You put an MRI in the mall and just get everybody through the MRI, and you put it on a screen and ask the radiologist to read it. They're going to give you the same degenerative disc disease, bulging this, bulging that, facet arthropathy, listhesis this way, that way, and most of them will not be in pain. And the only thing that it correlates with is age. I mean, as we start some degenerative disc disease as early as your 20s and 30s and 40s, so it's almost like measuring the rings in a tree to see how old you are, rather than saying that it's specific. So I mean, it's just age related, right?
True.
So by 70, you got 99% of people have all kinds of. I've never seen
I'm
a
sure.
perfectly normal MRI at that age. But at 30s and 40s, somebody says, "Oh, you got a back pain, you got a disc," and the person fixated on it, like, "Oh, my disc, fix my disc, I'll get better." So
bulge, sir.
bulge,
Bulge.
yeah.
They come to me, sir, I have a bulge.
Yeah.
I said, no, you tell me what bulge. And they're stuck to that bulge. They'll tell you 10 times, 50 times. And if you don't pay attention to that, they get more upset with you.
I tell the patient, if I had done the MRI the day before he had the pain, that bulge would have been almost exactly the same.
So, before we go further with pain, coming back to your flying, have you had any crisis situations or near crisis when you're flying and you had your heart in your mouth? What's going on? Am I going to land at all? Any such experience, either when you are flying or you're learning to fly or any of those things? Because sometimes when I was learning to drive the car, sometimes suddenly, how are you going to stop? I'm going to hit this guy. All of those things are going on. How does it, do you remember all the steps? I may forget. Anything like that?
I mean, throughout the training, they train us like for emergencies. Like the biggest emergency is the engine going out, because there's one engine. Everything else has redundancy. The joke is the propeller in the front is a fan to keep the pilot cool. Because once it stops, you'll see the pilot sweating. So luckily, I never had an engine failure. The nearest kind of issue was actually was flying in the clouds, like instrument flying back. I just it was a different plane. Regularly, I fly Cessnas. This was a Piper, so the low wing. The one we flew had a wing on top. There's a little bit difference in their electrical system.
Oh.
And so you're looking at how the ammeter, like we have a alternator and generating a battery. So on the Cessnas, the indicator is a little different. And this one, so I looked at it and said, it looks fine. But the Piper is set up a little different. So when it is looking like Cessna, it's actually not charging the battery. And I should have known better. It was totally, whenever you pick up a new plane, you're supposed to learn all its systems and all that. And I had done all that, but then after not flown for a couple of months, you get complacent a little bit. Luckily, I was flying alone, flying back. Then suddenly the radio started conking out, and I said, "Oh shit, the battery's dying." And so I immediately diverted. So I called ATC and said, "Hey, I need to land." Initially thought I'll make it to my home airport. Then I said, "No, I'll land right here." And I landed and came off, and the bat went dead. So, so what happens is, without the electrical system failure, you lose a lot of the instruments, and we practice that also, losing all instruments, like most of the instruments. They're backup instruments you can fly, but it makes it really challenging. But that was the closest I got to, and learned a lesson. So don't take anything for granted. To check, recheck. Just like when you do surgeries and procedures, you could never.
I think so. I think that because of you're also like a quasi surgeon because you do a lot of intervention work. I think those steps will also would have helped you to be a better pilot, probably.
Yeah, I think so. I think it helps. The
meticulousness.
Yeah, the checklist, and you keep going through the protocol, and hope never have to use the emergency procedures. So.
But I'm glad that you have to get trained on all of those things.
Yeah.
How far have you flown? What's the longest distance, or whatever
so about,
and how you measure by distance? Or
so I've flown I'm in Indianapolis to Tampa. It's about 600 miles. So with the plane we have to take a break every 3 hours, just to walk around. And
so you land and then go back.
Yeah, land, refuel, walk around.
Okay.
And then take off again. So that's about the longest I've done.
Very interesting. So the other thing is about your training to be an intervention pain physician. Before you go into interventional pain, what made you wanted to be a doctor from your childhood, or See, I want to be a neurosurgeon from 8th standard. That's what I kept telling everybody. Did you have any such stuff happening in a childhood or something like that got you to become a doctor?
Yeah, I'm the first physician in my family, and when we were young, first few years, we want to be engineer because my cousin was an engineer and things like that. And back then you were either an engineer or a doctor.
Correct.
Then I think looking back at it, I think I had post-viral asthmatic type attacks. So for a year or two, I had a couple of, just to get a little bit of wheezing, respiratory, for whatever reason. And we used to go to our local pediatrician. I remember his name, Dr. Jaiprakash, really nice guy. He would make you feel so comfortable. You walk in, and I didn't know what he did. I didn't know. He looked at my eyes, my tongue, listened to my lungs, and he would give me a shot and give you some pills, and you go home, and in a couple of days you start feeling better. And even before the medications worked, even before the injections worked, I felt so much good that I went talk to him. I'm going to feel better now. I almost
psychology.
Yeah, it was amazing. Then he kept like, like he was. So I said, maybe I want to be a doctor. So from that time onwards, every time I met him and he was close to our house, so sometimes we would run into each other. So, Henry, doctor, he was like, hey, hi, doctor, how are you? Like, that was like amazing. I'm like, wow, he thinks I could be a doctor, So
he has more hope on you than you had on
Yeah, he had more faith. I'm like, okay, then maybe I started thinking, I really like how he makes me feel. He seems like he knows so much. He's such a nice guy, he talks to me. He was not treating me like a little kid.
Huh.
He would talk to me seriously, and and he answer questions. So I felt this is a great profession. I want to be a doctor. I really didn't know what I wanted to do. So that's when it first came in. Then as you get older, I was like, man, I like to work with my hands. I like to do surgery, do something surgical. That was my thought process
During MBBS.
during MBBS and all the more things we did. I'm like, oh, cool. So like, for example, I knew I was not going to be a OBGYN guy. So that was out of the question. But I said, I'm never going to do this again. So I took every call I could take. I ran and did every delivery. I did every procedure I could ever do because I knew I was never going to do this again. And that's kind of my mentality with medicine. So initially I did a year of surgery when I went to US. Then I switched to medicine. I was a hospitalist. I loved it. And, the critical care part was really, then I was thinking of doing a subspecialization, like a fellowship. Somebody said, hey, you should do anesthesia critical care. So you're not doing critical care all the time. You've done a little surgery, you like to do procedures, it'll be great. So somehow I talked to the local, I was already married, a couple of kids. My wife said, you can do whatever, we're not leaving town. No, she's a sage. She tolerated all my...
Is she also a doctor?
No, she's
not a
not.
doctor.
She's an engineer, but she looked at my schedule once and she said, okay, I'm going to stay at home and take care of the kids. This is not going to work.
Good choice.
Yeah, no, I'm grateful. She's handled the family home front.
True.
So I went to the local anesthesia program and I talked to them and said, well, we'll see. And I did some, shadowing, running around, and spent a good couple months. And finally I got into the program. I was doing anesthesia and I did surgical critical care, which is a little different than medical critical care. And then I did pain rotation, and we saw some cancer pain patients, and this guy was like, man, I can ride my motorbike again. I have my life, things like that. I'm like, wow, this is amazing. Because all through our career, pain was, nobody taught us how to manage pain, evaluate pain, treating pain. And I thought, this is amazing. We can do things. And I started getting more and more interested. So I was the chief resident at anesthesia for IU that year, and they were preponing the surgical critical care. They were going to restart the program, and I'd expressed interest when I joined them. So then I went back to the chairman and said, look, I want to do anesthesia pain management. And I think initially I thought I'd do some anesthesia, some pain, but more I did pain, I said, man, this is what I should concentrate on. So I do some anesthesia here and there now, but mostly 100% pain.
Okay.
Very
So
good. I don't think you made a wrong choice at all, because I think...
No, I'm I was just lucky, and even I didn't expect all the things we're doing now and what we're able to do. So this has been 10 years back. Before I went into anesthesia, if somebody had, are you going to do pain, doctor, I would have said, what? Who wants to deal with pain?
Correct.
So,
I mean, imagine
yeah.
as a doctor and anesthetist, if you are thinking like this, imagine what the average man on the street or the woman on the street is even thinking.
Yeah.
And if you sitting in the US is thinking like this, you can imagine that, which means it's uniform all over the world that people are saving lives, doing these bigger things, the brain tumors and the bypasses and all of those things. The pain is somewhere in some corner, somewhere, like where, by the way, just, and then it's not life threatening. You medicate something, you go Tylenol or whatever it is you go, and then I think.
Yeah, even I went into anesthesia and pain thinking, how hard can this be? Anesthesia, you put them to sleep and they wake them up. And honestly, anesthesia is a lot of fun. I do miss it because it's like a physiology lab every day. You're looking at the SVRI going up, this pulmonary resistance going up, the oxygenation. It's amazing. I love it. But you don't have the direct patient care aspect.
That's true.
And the pain, sometimes, people say, I would rather die than have pain.
True.
And when you reduce the pain a little bit, so gratefully you can actually watch them walk in, joke with your front staff, and
very gratifying.
Very gratifying.
Sure.
I mean, it's almost like I do it more for myself than for my patients sometimes.
True. Yeah.
But yeah, that's been amazing. I never expected that I would have so much fun, so much joy doing this.
So, what is pain you've had from your library? I think you discussed migraine, you do post-herpetic. Anything else in your
Other pain I think I've had is something to do with postures. Um, every time, this is how I figured out. Every time I sat longer time on the laptop, I would get pain here. It would go up here to the neck, and then I would get a headache. Now I don't know whether it's a migraine headache or I don't know it is some other headache.
Yeah.
So after a long period of time, I figured out they're different.
Yeah.
Right. And another trigger used to be if I drove. Driving for a little longer period of time, it would trigger. So that's when I figured out it is more to do with musculoskeletal or ergonomics, what we call, than it was not migraine.
Yeah.
So that was another pain that I
Yeah.
went through. But yes, that didn't really bother me too much, though. Though it did hamper my work because I couldn't do
Yeah.
too much. Not that I work a lot on the laptop, but still, you
Yeah.
know, by the time I finish one report,
Mhm.
I'm kind of, I have to take a break. I
Yeah.
can't sit more than that. And if I drove little longer, I would want to take a break. Otherwise, it starts.
Yeah.
So some releases, some stretching, and some Ayurveda. Tried everything. And now I think I've got a hang of it. So I do the maintenance part of it, continue to do the stretching and keep it now, you know.
Yeah.
It doesn't bother me too much now. Yeah, once in a while it comes back when the trigger is there. When I have a lot of cooking to do, especially during Dasara and all, I cook for a lot of people. So those days when the strain is more, it comes back. But
Yeah.
I now know how to handle it. So I
Yeah.
become friends with the pain.
Yeah.
I know how to handle it now.
Now the pain does
Do you have-
teach you.
Yeah.
How common are patients like this who are coming to you all the time? Do you
It's
have?
the neck pain, back pain is one of the biggest
I think so.
area of pain in human beings. I mean, as you know, humans are the only animals that stand upright all
Correct.
the time. And if you really look at the lumbosacral junction and the cervicothoracic junction, it's not made for being upright. They're all, if you look at every other,
True.
even the bipedal, like
Chimpanzee.
chimpanzees and gorillas, they're not upright 24/7.
True.
They only for a few minutes, and then they're always putting weight on their upper extremities. So we put the most amount of stress on our neck, just the way our life has turned into. I mean, we are not out there in the fields and
True.
hunting and foraging or farming. We're sitting on our computers and things like that. This neck pain, back pain seems to be a very common issue. And one of the things, it's hard to, there's a big argument in the pain world or in general. Is it the bone or is it the muscle? So the bone guys will say, oh, it's the bone. You have to look, you can do an MRI, you can do a CAT scan, you can look at the bone. The muscles look the same. It doesn't look different. Muscle is hurting, you can do a biopsy and it looks the same. There's nothing wrong with it. So it's very hard to treat something that looks normal. But, we go back and forth. But in my thinking, the way I see how patients respond, I think it is more the muscle ligament issue. So generally, sometimes you remember this, sometimes you don't. The way the muscles get hurt, so when you sprained your back or did something and you stop using it, you lose the muscle really fast.
Right.
These athletes, when they break the bone heals up, but
Disuse atrophy.
the atrophy within a week, they're shown like 20-25%.
What? Really? That much?
Oh, yeah. So then what happens is your brain is not a muscle. It can do a lot of things,
Correct.
but it cannot move. So it does not. So you'll remember, 2 months back I did this. So you do that again. Your muscles are not ready.
Correct.
And they hurt. So it's kind of we do this all the time.
True.
And gradually it goes down. And the biggest, hardest thing for me to teach is patience, somebody like
Right.
you who's motivated, driven, a lot of commitments. You can't just sit down and say, I'm going to wait for this. Actually, that's the worst thing you
I
can do.
think if you ask me seriously, if I was left by myself, I don't think I would have handled it.
Yeah.
I think, but for his support, that constantly he's trying to figure out for me and trying to tell me, okay, do this, do that, and talk to this guy, talk to that guy, figure it out.
Or
That
talk to
helped
him on
me.
her behalf.
That
And then
helped
drag her
me.
there and put her in that.
But
scene
I
and do
think
something.
just left to myself, it would have been a disaster.
And she would not even
Seriously.
move to talk to anybody.
Yeah, it was
So because the pain is so
very frustrating.
I don't want to talk. You know, she'll grumble and this and that, and you know.
There are two things that happens. One is people like say, "Oh, you got there's nothing wrong with you. Just be stronger. You're just trying to avoid work, and you know you hear all that."
I've heard this enough from my patients. So that's why when I say this to them, especially the spouse, they get it. So when the spouse gets it, the patient feels very happy that somebody made my spouse understand.
Yeah, I mean, like no human being wants to go around life saying
Very
I'm in
true.
pain. There is somebody is always trying to game the system or you know want to, but true pain, I don't think anybody wants to.
Yeah,
So that's first part, like you said, somebody trusting you, believing you, and helping you. And second thing is finding the solution. But that's where you know a lot of times you do MRIs and you see a little bulging disc, and one of the neurosurgeons says, "Hey." The spine surgeon, let's fix this disc and we'll take care of it. And our human mind is so mechanically oriented. You know, we think, oh, if the engine is making some noise, you know, you go there, oh, the cylinder or whatever it is will replace the cylinder, everything will be fine. We think the human body is in the same way. That's how the human brain seems to work. Let's do an MRI, find out what's wrong. You hear that all the time. I said, man, if you do MRIs, we'll find something wrong. And the question is that causing the pain or is not?
Right.
And so we do a lot of
pain generators are so different.
Yeah. There's no, and that's one thing I tell my patients and other doctors is there's no test in the world that shows pain.
Absolutely.
The only person who can tell you what the pain is the patient themselves.
And you can't even measure.
Yeah.
The so-called VAS scale that we use, it is so relative.
Oh, yeah.
And it also depends on your mood. Like if you're in a bad mood, it is 10. Even if you're actually in a good mood, it can be 8. The same pain can be 8. So
the pain measurement.
You're saying it very right, because when my patients come and sit in front of me, they say I have back pain, and before anything they pull out the MRI, and they get restless if I don't look at the MRI, because they think, why is this guy not looking at the MRI?
Exactly.
And I say, I don't want to see the MRI. Tell me your story first. Let me hear from you what's going on. And then, you know, as they start going, I realize that, you know, that MRI has nothing to do with them. They have something else. They got a facet, they got a myofascial, it's a piriformis. There's so many things going on. So I think the reality is the knots in the muscle, so many things that is going on. And none of these, like you said, is picked up on the MRI. MRI don't look at it. And this clinico-radiological disconnect that is there, which is what makes it the trained eye will look at it. The untrained eye says everything is normal, you're just fibbing, go do some physiotherapy, whatever it is, get off my side, you know? That's not fair, because like you said, very few people will want to really suffer from the pain that is there. I remember you made a statement, you know, as we were chatting about, you know, this the podcast itself. And you said if every disc that is there bulge in the MRI scan we remove, we'll all become billionaires. What made you make that statement?
I mean, and there have been studies done where people just do MRIs on just normal people. You put an MRI in the mall and just get everybody through the MRI, and you put it on a screen and ask the radiologist to read it. They're going to give you the same degenerative disc disease, bulging this, bulging that, facet arthropathy, listhesis this way, that way, and most of them will not be in pain. And the only thing that it correlates with is age. I mean, as we start some degenerative disc disease as early as your 20s and 30s and 40s. So it's almost like measuring the rings in a tree to see how old you are rather than saying that. So, I mean, it's just age related, right?
True.
So by 70, you got 99% of people have all kinds of, I've never seen a perfectly normal MRI at that age. But at 30s and 40s, somebody says, "Oh, you got a back pain, you got a disc," and the person fixated on it, like, "Oh, my disc, fix my disc, I'll get better." So
bulge, sir.
Bulge.
They come to me, sir, I have a bulge. I said, no, you tell me what bulge was. And they're stuck to that bulge. They'll tell you 10 times, 50 times. And if you don't pay attention to that, they get more upset with you.
I tell the patient, if I had done the MRI the day before you had the pain, that bulge would have been almost exactly the same. So, yeah, MRIs are very useful. I mean, it's a great technology. It gives you amazing images. But unless you have the physician who can put the picture together and use it as a
True.
tool rather than the diagnosis.
Mm.
That is the answer. So that is a challenge. Both patients and physicians sometimes put too much faith in I call the MRI the family picture. You're always standing and smiling. Only you know who the crazy one is, who the
Correct.
things like that. So you can never tell. You can look at the MRI and say, "Oh, he looks fine," or something like that. So it's a snapshot at a given time in a given position. And sometimes I've seen perfectly good-looking MRIs in the pain, pretty much putting him in a wheelchair. And so I had an MRI, save it. This guy goes swimming, plays tennis, and every once in a while gets some pain. But if you look at his MRI, it's all curved. There's scoliosis, there's this, that. I'm like, what do you do? So I go swimming every day, sir. Keep doing it, it's amazing. So
Viewers, what Vinayak is trying to say, Dr. Vinayak, very clearly, is that we're not saying that MRI is of no use. We're not saying disc bulge. We're not belittling the disc bulge. All I'm trying to tell you is this. Number one is we're not treating the scan, we're treating the patient.
Right.
So that is where the beauty of a good clinician is. He puts all the pieces of the puzzle together and then decides whether what you're suffering right now, what the MRI is, where does it connect?
Correct.
Because eventually the decision is not to treat what's on the MRI. Our decision is to make sure that your pain becomes less.
Correct.
So unless we connect that, he may give you a beautiful post surgical picture, but if you have the same pain, then you're wondering, doc, you've done all these things, I have the same pain, because he's dealt with the wrong thing. So and the other extreme is there are people who don't get MRI done. They keep on treating sciatica. That's the other extreme. I still remember one story of a orthopedic surgeon's brother. Okay, he had this classical L5. He kept sciatica. He kept on treating, and 5-8 years, something like that. And finally, everybody got frustrated. I said, let us one scan, my brother, out of sheer frustration. And he had an L5 root schwannoma. He had a tumor sitting on that L5 root.
Wow.
So what I'm trying to make you understand is not doing the scan is a problem. Doing the scan has limitations. Eventually, all I'm trying to say is a right clinician who understands back pain, neck pain, makes the right decision is the key to make sure that the minimum effort is put to the maximum benefit you have for the longest period of time. And I think that's the message that we want to give, that there are different ways to skin a cat, different ways to look at it. And unless we get the full picture, we'll be doing disservice to our patient, because these are all wear and tear stuff at the end of the day. And I think that's what goes. So let us say, Vinayak, that going forward, you've had an actual neck pain, back pain patient. The usual stuff hasn't worked, the medications, the physiotherapies and everything else, the myofascial releases, or it did work in the beginning, gotten worse and things like that. He's not an actual candidate for surgery because he doesn't have a surgical, lesion, for example. What other tools as an intervention pain physician do you have in your armamentarium that you can help such patients reduce their suffering and improve their quality of life? Can you tell our global viewers about that?
Yeah, I think the pain, like we said, we can't see on MRI's images and based on the description. So I divide the spine into the more, initially when I was learning, and even for the most part, you say back pain. That's like saying you have heart disease. Now we know, now we've gotten so clear with the diagnosis. We know it's the vessels or the muscle or the nerve, the electrical system. It's, nobody talks, you got heart disease, you take a heart pill. So saying you have back pain or neck pain and saying you have back, that's a disease, is very similar. So we've got to break it down and try to figure out where it's
More
coming
specific.
from. So just having a thorough history, like talking to the patient, saying, what could you do now? What don't you do now? What kind of things? So it helps to sort out. I mean, some people become very dogmatic and say, if you do this and this is the pain, then it's a disc pain. If you do this and this is the pain, there's a facet pain. There's a lot of overlap. And I explain to the patients, as you know, our 2-point discrimination in your fingertips is a couple millimeters. In your face, it's a couple millimeters, few millimeters. On the back, on the skin, it's maybe 4 or 5 centimeters. So that's about this wide. And I touch a patient and say, how many fingers? And they say 1. I say, no, it's 2. And that's your skin. So when you go internally, your brain and body, the nervous system is not set up.
True.
You have a heart attack, and they say you can go to the jaw, you can arm hurt, and you have gallbladder pain, you can have left shoulder hurt. So the brain, the internal organs are not innervated as
Right.
clearly.
Systematic.
So just saying my pain is somewhere here doesn't automatically. So we talk and discuss what's going on. So then I use my interventions both as diagnostic as therapeutic. So if I numb a particular tiny nerve that goes to the facet and the pain gets a lot better, that suggests it's probably coming from the facet. Or if it helps some and it says, well, that pain is gone, but now I have this pain. We see a lot of SI joint pain, the sacroiliac joint pain, that gets missed because
True.
it's a
Right.
poor orphan joint. It's the spine surgeon don't look at it
Correct.
because it's below that, and the orthopod's like it's too close to the spine. So poor thing, it's sitting there, and just as we're sitting now, the other upper body weight is going through the SI joint,
Correct.
and it's a very commonly missed one. But that's why I use interventions to say, hey, is it the facet? Is it the disc?
You
Is
can
it
do
the...
diagnostics.
So in my mind now, kind of think about, is it the anterior segment, which is the vertebral body, which is the little round things which everybody looks at with the discs, or is it the middle segment where I call it the elevator, where the nerves go, the spinal cord goes up and down, and in each level of the elevator there are doors, and the nerves leave that door. So that could be the middle segment, and the posterior segment is the facet joints, the little joints that help keep you aligned and bend and twist, and the muscles around it. So when you start thinking in those sections, I think it helps make the diagnosis a little bit easier. The anterior segment is the hardest. Unless you have a compression fracture, that's pretty easy for the anterior segment. But other than that, the disc pain is hard. So we use it for diagnostic, and then we can do more aggressive treatment like burning some nerves. We are getting more and more minimally invasive approaches. But the injections do help. Some people do some injections and they're great. I'll see you next year. Other people, yeah, it didn't help. But at least we know where it's coming from, then we can focus on how to treat it better.
But since you mentioned the SI joint, I want to tell you my personal experience, one story. This gentleman was 80 years old, close to 80. He was a father of a professor of neurology at NIMHATS. And he was having this back pain. Like you said, the MRI didn't show a surgical stuff. He's struggling. Everybody said this, that, and eventually, he was struggling to even walk to the bathroom. And eventually somebody heard I do certain different things, and he came to me, and I saw that I realized it was SI joint, and I got my pain physician to intervene. And he gave the temporary injection to this one. And on the operating table, the pain went away. And this old man was ecstatic because 2 days later was his 80th birthday. And he told my pain physician, this is the best 80th birthday gift you have given me. And he had such a big, bright smile on his face. You can put $1 million on that. Poor old man was struggling. It's a small thing that we did, but for him, it was the world of difference as far as pain and no pain and quality of life is concerned. I think we should not underestimate what our patients are going through, belittle it, and then casually brush it under the carpet. I think that's very unfair that we should do that. And luckily, many people like you and me are trying to address that very proactively. And I think that will make the world definitely a better place to be. So now you spoke about an intervention doing the facet that you do radio frequency ablation. Are there anything more that you do, to the roots, to the this one, anything else that you intervention pain wise? What else do you have to manage pains?
So I think the most common is the posterior segment, the facets, because we're bending, twisting. 80 to 85% of all our stress is at the L4-5, L5S1 level. And then
what do you do with the facet? You didn't explain to them clearly what do you actually do.
So the facets are the little slip and slide joints in the back. So if there is none of the facets, your whole spine would twist round and round. So it's holding it in place, but then it has to allow bending and twisting. So those joints, we used to try to inject the joint itself and all that, like we do the knee joint injections or hip joint. Because
where do you do that? Is it done in an outpatient clinic or what do you
most of this can be done outpatient. A lot of times people are nervous about, somebody's going to put a needle in my back and all that. They can't see. So I give them a little bit of Valium-like medication just to take the edge off. A lot of times.
But it's done under X-ray.
Yeah, I use X-rays because these are tiny nerves, go to tiny joints. You cannot, if somebody's trying to do injections to the facets without X-rays, it is probably half the time you don't know where you are.
Right.
So we numb the nerve and they get better. The next term is we call it radio frequency ablation. In local terms, we call it burning. Or so basically, what I describe is it's scrambling the nerve. It's not burning the nerve like you were putting fire and like cauterizing it. So it's temporary.
That's true.
So like you scramble the proteins in the nerves, so it stops working for a while, and then over a period of 6 months, a year and a half, everybody's different. The nerves regenerate and things like that, and the pain can come back. But then you can repeat the injection as needed. Then I tell my patient, if you don't take this time and the pain is better, to strengthen those
Yes.
latissimus, the
Rehabilitative.
longitudinous muscles, the tiny muscles in the back that are very hard to activate, and things like that, you'll be back. And I'll be happy to do the injection. I love doing it. But if you don't use this time and you're better and keep working at it, it's like anything else. If you maintain your muscles in your body and all that, you're much less likely to have pain. Having said that, there was a paper that came out of Australia. This is about ballet dancers. So who could be more fit than a ballet dancer? I mean, they have core muscle, they have flexibility, they have aerobic condition, and a segment of them have back pain. And the only difference they could tell was that the little longitudinous muscles was not activating as well as the other. So yes, it is good to lose weight, good to have exercise, but you can't just say, "Oh, I'm doing all this and the pain will go away." You see pain in thin people, you see in fat people, you see somewhere in between. So, yeah, I think it helps, but anybody can get pain and we'll find ways to solve it. Like, I'm not, again, well versed in, I'm starting to learn about the yoga aspect, the breathing. I used to make fun of it. How can you breathe? And did you breathe funny through one nose?
It works so well.
And you start looking at how it affects how it stimulates the parasympathetic system.
True.
It deals with
You said
anxiety.
vagal stimulation with pranayama. You can do that.
Yeah.
That works very
So
well.
it's called prana. Prana is life,
Yeah.
actually.
Life.
It's not just breath, actually.
And if you really look at our ancient systems, yoga abhyasa, what we talk about yoga, like all the postures and bending and all this asanas, it comes what, fourth or fifth down the list.
Yes,
I mean,
in the Ashtanga yoga.
Yeah.
Yes.
So people don't realize. They said yoga means sleep, diet,
everything.
How you think, what's your, and it's a whole lifestyle.
Yeah, absolutely.
And when you're young, you're like, yeah. When you start learning it and going back and seeing
Makes a lot of
patients
sense.
in pain, you say, wow, this is huge. And getting the buy-in. When you hear yoga, it says, oh, this is all religious thing you're doing and all that. Like, no, it's nothing to do with religion.
Exactly. And what about root blocks? Something? What did you do? Any of those things? Steroid injections for radiculopathies? What?
So that's the middle segment you're talking about, the elevator where the nerves go up and down. And so spinal cord has two conflicting jobs. One, it has to give you a lot of protection to your spine and your body, and that's the kind of so it has to be rigid and strong. But also the nerves go right through it. So it has to allow them to go out. So it is trying to do two things. It wants to make sure all the nerves go where they need to go, protect them, but at the same time be flexible. So at some point,
like a mobility plus stability is a very complex process.
Yeah, so it's trying to balance those two. As we get older, then the bones start developing like osteophytes, the ligaments get thickening, and the only thing that cannot push back is the nerves. So the nerves can get squeezed either in the middle of the elevator or as the door is opening up through the channel. And most of the time, as that gets there, we think it's more a mechanical issue. A lot of times injecting a little bit of steroids and numbing medicine right around those tight areas can help. It's not, it's automatic, like the cardiologists go after, there's a narrowing, we'll put a stent. So it's very tempting to say, hey, there's a narrowing, let's put it. But a lot of people with narrowing with very little pain. And there have been studies where they took some tissue and studies, there's a lot of inflammatory markers, there's a lot of, so just because it's a mechanical looking, it doesn't mean automatically you have to fix it. So there are things conservative, like people say, it's narrowed, why should I do physical therapy? I'm like, no, there's inflammation, there's So the injections can help buy you time,
Mm.
go through the rehab process so they can uh, get better. So I
Right.
said, the injection helped for a few months. It came back, I'm going to have surgery.
Mm.
Well, that is what it is designed to do. I'd put steroids one. It's not like doing an appendectomy. Once you take the appendix out, you shouldn't get one. If you do, you should talk to the surgeon that did the first one, right?
You have to remember indication of appendix, presence of appendix was
Yeah,
the joke that we had when
yeah,
we were
it's
in
true.
MBBS.
No, but
At that time, I never understood what's the
True.
satire of that, but now I
yeah,
realize what was going on.
the poor appendix, man. They just go beat it, take it out. If it's
If you don't find anything
yeah.
else.
It's crazy.
So yeah, that it'll help when people get function, and then
Mm.
you should get all of the right. I think the biggest thing is the patient has to buy into that,
Yeah.
and that's a challenge because
I understand. In fact, being a neurosurgeon and being also a spine surgeon, I do quite a lot of spine surgery myself and my team. But yet, I feel somehow that I'm still very conservative as a surgeon compared to many of the other spine surgeons who are currently operating. And somehow, suddenly, I see the last 10, 15 years, this putting the screws in the back, putting this has become like a fashion rather than an exception. And I believe that, through this podcast, I want to tell everybody that every disc doesn't have to be operated. Every operation does not need a screw to be fixed. I think I somehow think that if there are some very aggressive spine surgeons who are, operating all the time, doing all of those things, I still think that I tell even my patients sometimes, I have to convince them not to get operated. And some of them go and get operated in spite of me telling no, then come back with the symptoms and say, I should have listened to you.
yeah,
Because the pain is coming from somewhere else.
Mm.
So, if you have a hammer in your hand, everything looks like a nail. It's not so true
Yeah.
in spine, especially like you're saying. It's so multifactorial, the
True.
sources are so different. So I think that, with 25 years of practice and understanding spine as an integral part of my practice, and also running rehabilitation and so many other things, I believe that if aggressive spine surgeons are doing 10 surgeries, out of which only 3 or 4 actually need surgeries, 5,
Yeah.
6 of them don't need surgery. There's so many non-surgical ways of fixing it, including intervention pain like this. And on the other side, if you have 10 of them who are getting screws in the back, only 3 or 4 of them need the screws. Rest of them, we can maintain preserve the mobility and the stability and not having to, because by making sure you don't destabilize the spine.
Correct.
So the techniques are very important for you to do. And we have patients who have done all of that because truthfully, I'm quite sure you agree with me that there are a lot of people who have got screws in the back and adjacent level instability has become a common problem and things like that. So
Correct.
people are actually revisiting and saying, is this a solution to all ills? Because the spine is moving differently. You're fixing everything. The biomechanics will change and things like this. So I want to, inform our viewers that you have to be very circumspect in what's going on. And don't jump in a lot of things. But unless there's a neurological deficit,
Yeah.
the classical thing, matching the neurological deficit, then maybe it's maybe useful. But there also I have seen situations where somebody is having a GB syndrome and they've jumped in and removed a disc. Then realize that it's lumbosacral plexopathy or it's a GB syndrome evolving. I'm just amazed at what all people are doing. So clinically very, very important to be seen by us, a trained guy, preferably a neurospine surgeon who understands what's going on. Here I have taken a call many years ago that me and my pain physician work in tandem. And if there's no neurological deficits, I'm convinced is coming from a pathology in the back, then I send to him to say, can you fix it?
Yeah.
And only if he says I can't, then we sort of talk and then we take the right decision for the patient.
Yeah.
And I believe that after doing this work, my spine surgery has come down 50% from an already conservative situation. I have no regrets because I think I'm doing the right thing for the patient.
Sure.
And that's the key. That's why I thought talking to somebody like you will be very valuable, because the end of the day is we are trying to make sure it's not that you are better or I'm better or my technique is better, your technique is better. The question is, what does the patient need for to solve that problem, and which is the minimum required, because you can live to fight another day. And in that way, I feel that pain interventions are much minimally invasive. You can always go back and operate if it just fails if you feel that that's not working, but not the other way around. What do you think about what I said?
Absolutely. I mean, it's hard to get somebody like you who understands pain, understands rehab. We all give lip service, go to rehab and go to physical therapy. And as I starting to understand it, I think it's more the muscle ligament, how different things heal differently. Then start paying more attention. But a lot of times we are trained in a certain way, like you do this, and if this shows up, you do this surgery. And the vast majority of the surgeons and the pain doctors are all thinking like we are doing the right thing because that's how we were trained. But if somebody goes back and looks at, like you said, on wise old surgeon said, uh, like back surgeries, the 30% get better, 30% get worse, and 30% nothing changes, like a third. And that's kind of what you have seen in your experience. About a third of them need the experience.
True.
So I think we need to do a better job of picking who succeeds in surgery. I mean, I don't think any surgeon wants to do surgery and patient come back and say it didn't help me or made me worse. And I think as a system, we should figure out a way to give the maximum, I think the surgeons, like a true multidisciplinary surgery where the right patient gets the right treatment.
Correct.
And everybody's, will never be 100%, but I think that is the way to go. Yeah.
So just to add to what you said, it's an anecdote. I was operating in a charitable hospital once, and the patient had a MRI said a 2-level disc, L4-5 and L5-S1 slip disc. And I had posted him only for a 1-level discectomy, macrolumbar discectomy. And there was an orthopedic PG was assisting me in the surgery. So during surgery, he asked me this question. He said, how do you know this is the disc causing the problem?
Yeah.
And it's a valid question.
Yeah.
Now I gave him an answer that he couldn't forget. I said, see, if after surgery, if his pain is gone, I've removed the right disc.
Yeah.
If the pain is there, I've removed the wrong disc.
Yeah.
And he couldn't believe my answer. He looked at me like this, and he thought I was nuts.
Yeah.
And I did what I did. He assisted me. He can't do anything because I was the consultant surgeon. And post-op, after 3 hours, he called me back. Sir, the pain is gone. I said, are you happy? I said, the meaning is you don't have to remove every disc that you see on the scan.
True.
So you have to understand how to connect the dots and know what is going on.
Yeah.
And L5 and S1 are two different things. You got the root values are different. The pain distribution is different. You have to know what is going on. That's what is very important for you to understand.
Correct.
You have to be able to be so much more scientific, much more evidence-based, and much more clinically oriented than just, keep removing everything that comes your way. And that is, I think, the most important thing. So what's going on in your mind listening to both of us going back and forth
one more
on this?
area I would like to talk about, which I encounter, which I see patients, is fibromyalgia. I think mostly seen in women, and they again come up with vague pain symptoms. So what's your experience on that? Because I see a lot of them.
Yeah. So a lot of interventional pain docs just run away from fibromyalgia. They say, what can I do? I'm not, if you go after every painful spot, you'll be injecting like your pincushion in the body.
It is difficult.
And it is. And again, it's another disease, no blood test, no imaging.
Absolutely.
Everything is normal.
Yeah. And it's, middle-aged younger ladies.
Yes.
Oh, it's all in her head. She's, things like that. It's
menopausal,
psychological, postmenopausal.
Yeah. So it's a challenging one. And so again, first of all, accept that the patient is in pain, trust them, and give them some feedback. Look, this is a challenging disease. And I think most people will appreciate that you're telling them that at this point we don't have much to offer.
True.
We work on their,
Psychological
issues.
aspect.
They all get depressed. Most of them have sleep issues.
Yes.
So I think I order more sleep studies than a lot of primary care doctors. Because they have, it's a sleep, and that's another. We can talk about it for another hour. The sleep and pain.
True.
And then
you can tell 5-10 minutes on sleep and pain, because I think it's very valuable if you think there's so much for our listeners to at least get a context of overview of that.
So it's a chicken and egg. People start hurting and they can't sleep well and the pain gets worse, or is it because they're not sleeping and
it gets
the pain
aggravated.
gets worse?
True.
And I say it doesn't matter. We're trying to break those links. So we need to work on your sleep cycle. We need to work on, so obstructive sleep apnea is relatively easily treated. So we'll look for that. A lot of them have restless leg, and you treat those. So once they start sleeping better, work on the depression aspect, things like that. I'm conflicted about, medicating everybody, but sometimes that's the way to go. I think the last thing, is not as much of a problem here in India is the opioid use and fibromyalgia.
True.
And the understanding is we don't know exactly the pathophysiology, but we all have a pain system, the endorphin endogenous pain system. and it's somehow misfiring. And actually using naloxone-like drugs seem to help. It's just we are finding solutions. So one of the newer frontal waves we are looking at is, I think there's a balance between in the autonomic nervous system, between the sympathetic and the parasympathetic. We never think of the sympathetic, parasympathetic in the pain system, but we're starting to do more stellate ganglion blocks. It's not a permanent solution, but I have had people come and says, "Wow, I feel better. I can tolerate the pain better." I'm not sure what exactly I'm treating, whether it's the anxiety and the pain or is the pain itself. But stellate ganglion blocks are being used for PTSD, anxiety, depression.
Interesting.
But it has helped a lot of pain.
Right.
So again, it's a challenge in our insurance-driven world
Right.
to get it approved. But it's a relatively simple injection and a good interventional pain doctor. Using the proper either fluoroscopy or ultrasound guidance, it can be very safe. You are going into the neck with all the vital structures,
Correct.
but it has done well. They're always trying new medications, things like that. And we're starting to look at vagal nerve stimulation. And again, these are hard to get approved by insurance and all that. The vagal nerve seems to have a huge impact on chronic pain.
True.
And I think it's just exciting, and
Correct.
we're just kind of trying to push the envelope a little bit. Every once in a while, if it's pretty severe, and I've done like ketamine infusions for pain, and this is not like knock them out, and just a little dose to reset the receptors, and seemed like help. So it's a multidisciplinary hand-holding complex. So you need a good cognitive behavioral therapy type approach, good lifestyle management.
Absolutely.
These people, their sleep cycle are messed up. Their food is messed up. I'm starting to learn about diet. We're like, diet. But you're starting to understand, since I take the approach like, I'm trying to find a solution for you. I'm not trying to find a patient for my procedure. And sometimes I just tell them, let's try this, and they get better. So I don't do a procedure, but that's okay. I got a patient better.
Yeah.
That's the bottom line.
So he's talking about CBT, cognitive behavior therapy.
No,
So
that's what I've had a
what's
very
your-
good experience on this, because I put them onto one CBT. Second, working on their sleep pattern itself, giving them that sleep hygiene, working on that, discipline, lifestyle, diet patterns. I've done a lot of work with pranayama. That has helped a lot of my patients. Calming, because they're so anxious. So calming them down along with the sleep, all these things has given me a lot of good results. So CBT definitely works very well.
So like you're reinforcing what Vinayak said, that it is multidisciplinary.
Yes.
You have to have everything coming. You have to treat the physical aspect of the pain, the psychological aspect of the
And
pain.
other big problem with these people are they're middle-aged, and they have a lot of responsibility on them. They don't have time. They can't figure out time. So one thing I sit and do with them to figure out time for them. When do you do what? Put their daily routine work, working on their sleep pattern, just telling them, okay, do this at this time, do it for 1 week, come back to me and tell me, is the schedule working for you or not? Oh, this has helped a lot of people.
Get a method in the
They
madness.
need a little bit of a guidance and I think somebody who will push them to make that happen, because you write it and give it to them, they'll do it one day, as usual, like all of us do that. Second day, third day, it's when
Life
there is
happens.
excitement, they want to do it in like maximum 1 week. After that, it disappears out of their routine. So when the follow-up calls are done and they brought back and they given this helping hand, I think a lot of people have got benefited.
And
Pharmacotherapy, of course, with that.
I'm not, again, well versed in, I'm starting to learn about the yoga aspect, the breathing. I used to make fun of it. How can you breathe? And you breathe funny through one nose.
It works so well.
And you start looking at how it affects how it stimulates the parasympathetic system.
True.
It deals with
You said
anxiety.
vagal stimulation with pranayama, you can do that.
Yeah.
That works very
So
well.
it's called prana. Prana is life, actually.
Life.
It's not just breath, actually.
And if you really look at our ancient systems, yoga abhyasa, what we talk about yoga, like all the postures and
Correct.
bending and
Asanas.
all this asanas, it comes what, fourth or fifth down the list.
Yes,
I mean,
in the
first one
Ashtanga
is-
Yoga.
Yeah.
Yes.
So people don't realize. They said yoga means sleep, diet,
Everything.
how you think, what's your, and it's a whole lifestyle.
Yeah, absolutely.
And when you're young, you're like, yeah. That's fine. But when you start learning it and going back and seeing
Makes a lot of
patients in
sense.
pain, you say, wow, this is huge. And getting the buy-in. When you hear yoga, it says, oh, this is all religious thing you're
True.
doing and all that. Like, no, it's nothing to do with religion.
Exactly.
And you have to do the whole process. It's not
Absolutely.
just do these 3 postures in your bed.
No, it
So,
isn't.
Yeah, people look at yoga as an exercise, which
Yeah.
I tell them
Yeah.
it's for
Which
wellness.
is, the asanas typically is exercise, but if you take the Ashtanga Yoga, yama, niyama, asana, pranayama, pratyahara, dharana, dhyana, samadhi, yes, we don't go to that level, but at least rest of the 7, definitely doable. And it definitely helps.
And you have to do it together. And that's,
Yes.
I know I'm an interventionalist and I'm conventionally trained physician, pharmacotherapy,
Correct.
things like that. But then you realize, step back, the whole system of life, how you live, is what helps in the end.
Absolutely, Vinayak, because you made a very important statement. I think the Western system of medicine has a lot of limitations.
Yeah.
We are great at surgery, critical care, those things. But beyond that, those symptomatic treatment, we're not getting the root of the problem.
Yeah.
Like you said, the simple thing like sleep hygiene.
Mm.
You don't have to be a rocket scientist to figure that out, that if you don't sleep well, next day you're restless and things like that.
Yeah.
Diet has its own impact and so on and so forth. So I think we have to be more holistic in our approach,
Yeah.
multidisciplinary,
A combination of
everything else.
everything, I
Not
think it
ridicule
works.
other things just it doesn't look like that, something this and this. What I don't know doesn't exist is a wrong attitude that many of the doctors have. And I think through this we want to make people understand that what don't know doesn't mean it's not important. And the more we know that we don't know.
Yeah.
And the more people are going back to the roots to understand what is, this beyond the
True.
physical aspects and things like that.
And little bit of understanding of Ayurveda with these patients, like simple things like Shirodhara. They have some procedure called Shirodhara, where they drop on there's a liquid or a oil which is dropped on a particular speed, and there is medicament in that. That gives a lot of help on anxiety, controlling the anxiety, sleep disorders. It helps a lot. So I make a combination of that if people are open to it. It helps. So combination of all these things makes a lot of gives them the results.
Eventually, we have to find the formula that works best for somebody with minimal side effects and which is more compliant to them.
True.
That's the bottom line. Like he said.
Same formula doesn't work for everybody.
Absolutely.
So it's a mix and match.
For the same patient every time.
Exactly.
It's also, repeat all. You can't just carpet bomb the whole thing. And that's the habit many people have to say, I repeat the same thing. You can't do that.
Correct.
You mentioned vagal nerve stimulation. So, that will take us naturally into the next level, which is neuromodulation. And you were talking about diabetic peripheral neuropathy. You do a lot of work on that. So can you tell our viewers that what's the work that you do? Because diabetic peripheral neuropathy is a mess, especially after some time, especially India being the diabetic capital of the world. They're literally saying every other Indian, every third Indian is a diabetic. And, and many of them are not disciplined enough to get their blood sugars under control. And because of the blood sugar variations, the peripheral neuropathy is happening sooner than later. And initially, it looks all hunky-dory. They just take some medicine and they're okay. But sometimes they're distressed by that. So what's your take on that?
So neuropathy, the diabetes, a lot of times people don't even know they have diabetes and they already start having neuropathy. It's the nerves, and it's a interesting thing why some people have such bad neuropathy and other people don't have much. Some people are totally numb, but they have no pain, and other people have, I can feel it, but my pain is worse. So why some people are more painful than others, it's hard to predict. But about half the people with diabetic neuropathy do fine. They take some Lyrica, Neurontin, Tylenol, and they're good. But there is other half is just miserable. And so I tried all the medications, supplements, magnesium, vitamins, and a few of the patients just are miserable. So the one thing that has done really well is spinal cord stimulation. So the dorsal column stimulation by the epidural space has done very well. So I use the 10K hertz system, which is 10,000 hertz frequency. It seems they had the biggest study on diabetic neuropathy, and the number needed to treat was like 1.5 1.5 or 1.6,
Okay.
which is unheard of, you know, like Lyrica is like 12 or 9 or something like that. So just for an example, number needed to treat is for the lay people, it's a surrogate marker for how effective the treatment is.
Correct.
So if you treat, if the number needed to treat is 9, you have to treat 9 people to get 1%, 50% relief. So that's kind of the math they do. So 1.5, 1.6 is amazing. It is an invasive procedure. You know, you have to implant a stimulator and
Expensive.
Yeah, expensive and also, but we do a trial. So when I put an implant in, I do it, put a temporary one, send them home for a week. There are a lot of people who do 3 days trial, 4-day trial, but I think at least 1 week is the minimum. And sometimes I extend it because I want the patient to be sure it's not.
Yeah.
So
Because-
both of us have to be sure.
Yeah.
So I also do that, and we have to be 100%
Correct.
sure.
Because you know, when they're so much in pain, they put hope on something. And the first 2-3 days, they get a
The
placebo
placebo.
effect. They're
Correct.
Like, so I said, no, wait till 7 days. And it has done really well. People say, I can feel my feet again, I can walk again, and things like that. The other holy grail of diabetes is limb preservation. You know, they'll start getting ulcers and things like that. We don't know if that is still a possibility. I don't promise them that you will never get an ulcer or you'll never have an amputation. But early data does seem to indicate that. So again, it's something to do with the sympathetic, parasympathetic.
I think so.
Going back to neuromodulation, you know, I started kind of started clicking in my brain about sympathetic versus parasympathetic and all that. Not many people know this, but they tried the spinal cord stimulation for congestive heart failure.
Really? I think I read it somewhere.
Yeah.
That's right.
So
Or even intractable unstable angina, I think.
Yeah, they tried unstable angina, VFib, VTAC. It's very helpful, spinal cord stimulation in thoracic. So Doug Zipes is a big electrophysiologist in IU, Indiana University, where I'm. A good friend of mine was his fellow and his resident. He did a lot of the studies. So I went to the lab, saw them. The reason I bring that is, so they did a whole, so they saw some subgroup analysis in the unstable angina study that it helped congestive heart failure. So they took these dogs, induced heart failure by blowing up their LAD with beads and pacing them at a rapid rate. So they basically got a dilated cardiomyopathy. And you walk in the room, this poor dog is like kidney matters and is fatigued and sluggish. So they did spinal cord stimulation on it, and they did really well. And one of the things they did with all this study was they put vagal nerve electrodes. They measured all kinds of things, the catecholamines in the body and all that. And they saw that the vagal nerves really, the sympathetic system quietened down, the parasympathetic did really well. I mean, they could measure all that, and the docs did really well. So they presented the paper. They said, hey, wait a minute. Human beings get the best medical care. They get ACE inhibitors, the carvedilol, LASIK, whatever. So they did another study where they did a 3-arm. One arm got drugs only, one arm got drugs and stimulation, and the third arm got stimulation. And stimulation did the best. So
Plain stimulation.
yeah, not vagal. It's a spinal cord.
No. But without the medicine, just the stimulation.
Yeah. So, but it's still, animal study, and there's still a lot of work to do. But what it showed was it really changed the sympathetic parasympathetic system. We use beta blockers in heart failure anymore because of the. So I think that's what is happening with chronic pain, and that's kind of I'm starting to think about chronic widespread pain like fibromyalgia. There's Ehlers-Danlos syndromes. People have hypermobility. They have all this vague pain. And we talk about the vagus nerve. So that's kind of started opening my mind, is like, maybe you're not looking at all the right targets. So that's where I think one of the things is happening is it's reducing the sympathetic tone in the leg, improving the parasympathetic tone. They do well. So diabetic neuropathy does really well with stimulation. CRPS is one of the. I used to run away from CRPS. Don't come to me; it's painful. I know. But now with stimulation, I can
only you guys can help.
do really well with that. I mean, that's another talk about another disease that is life
Very
altering. So the targets we're learning, one is the conventional dorsal column. Now we're targeting the dorsal root ganglion.
DRG, that's right.
We're targeting peripheral nerves. So it's kind of coming a long way.
I know.
We went to medications, now we're going back to the nerves. So our ancient forefathers knew something about
I'm sure.
the vagal nerve.
True.
So,
No, vagal nerve has really no question about
so
potential.
I think the future is neuromodulation, and I think it avoids the liver, kidneys, your brain. It doesn't affect your cognition. And I know at this point it's expensive and there's a lot of things, but I think as the indication expands,
Correct.
I think the value that people, I mean,
True.
In fact, if you look at a book, Rebooting the Brain, the concept I'm promoting is called functional neuroscience, which is neuromodulation with neurorehabilitation.
Yep, absolutely.
And the whole thing merging together seamlessly is what, and going back and forth, is what will give the best quality of life, I feel, for our patients.
Getting
I
the
think-
functional outcome
and
of
I
the
think
patient.
you validating that, I think, is an important thing to know for sure, because as a functional neurosurgeon, all these implants is a part of what I do or what I recommend to do. And I think with acute care being, longevity increasing routinely and acute care keeping people alive for longer periods of time, the quality of life
Correct.
surgeries will definitely play a role sooner than later to make all these things happen, no question. I think now we'll go to the last segment, of which is regenerative medicine, that you said was very close to your heart. So what is this concept of regenerative medicine? What are you regenerating? What are your techniques? What do you do? How does that have a role in pain? I'd like to know.
I think regenerative medicine sometimes, it's oversold. So a few years back again, when I'm looking for solutions for patients, I have all these patients, I'm like, what do I do? I hate to tell them because I'm the last resort. They come to me and say, everybody said you're crazy. There's nothing we can do. You'll be in a wheelchair, take narcotics for the rest of your life. I'm like, no, so I started reading more and more articles and hearing more about using your own body's healing process. So one of the ways is we use your platelets. So you take your blood out, spin it out, concentrate the platelets, and put the platelets back in the thing. So it's not really regenerating. Like, people imagine suddenly cartilage growing from
Correct.
nothing. And
True.
so you have like stage 4 osteoarthritis,
New arm growing.
new disc coming up and all that. That's not what's happening.
Not yet there.
So we talk about stem cells and all that. So I think what is happening is we are actually helping the body heal itself by boosting the process. The platelets, we know all about bleeding, but the first thing it does with an injury is stops the bleeding, and then it starts the cascade of the healing. It starts attracting the proper cells, secretes like 1,000 different chemicals and from its granules and all that.
Right.
So we realize platelets are very important. So that's a very common way. So you have tendinitis, arthritis, things like that, and people are trying to avoid surgery, control the pain. That seems to be the way to go. It's like saying laser surgery or something like that. Not really laser, but we're using. It's catchy to say regenerative, but it's more boosting your own healing process. It's safe. You're not using anybody else's blood. It's your own blood. Sometimes we use bone marrow. Sometimes we can extract some cells from the fat cells. So that's one good thing about fat now. So at least it's used for whatever reason. It has some
Right.
stem cells like.
So don't say that people will
I know,
eat more.
like-
I'm growing my stem cells. People will have some reason to eat more pizzas and all of that nonsense.
So that's the direction we are looking at. What can we do? I'm in a kind of a unique place in my career. On one hand, we're doing this cool stuff and looking at spinal stenosis. I do endoscopic. We put cameras and break it up, and I put little devices to make a little space. We're burning the basic vertebral nerve. We're doing. Even when I finished my fellowship about 14 years, 15 years back, and to now, I would never have imagined what we're doing. But at the same time, pain is so common. You put cancer, heart disease, diabetes combined, there are more people with chronic pain by definition.
True.
At least in the United States, there's more
I
than.
think
I think it's
Everywhere, I
universal.
guess. Yeah.
And doing cool procedures, implants is not the solution long term. I think some people will need it, and we should have tools for those people. But ideally, it will be better to keep them from going there. So keep them into chronic pain, catch them earlier, and get people not to ignore their symptoms. Learning from our history and other experiences, acupuncture and all that. You get the best of everything.
Correct.
to keep people functioning, because that's what they come to you. They don't come to you and say, "Can you fix my, cool
Remove my disc,
MRI?"
yeah.
I want to go play with my family. I want to do
True.
this. I want to
Grandchildren, yeah.
keep working. I want to do what I want
Yeah,
to do.
true.
And I think our job is to
Enable
provide that.
them,
That's a
Yeah.
very
provide
important.
them
Yeah,
that.
they
Yes.
they have a problem, they want a solution,
Yeah.
and they have a scan.
Yeah.
So how are you going to mix all of that to give them the solution that they want is the key, I think.
I think sometimes modern medicine trains people like there's a pill for every ill. You come here, we'll write a script, or if not, we'll do a surgery and we'll fix you. And there's
Which
a
is
role
not
for
the
that, but
truth.
I think that's
Yeah,
a small part. And I think the
It's
way,
not black and white.
yeah,
There's so much of shades of gray in
Yeah.
between, especially in
Yeah.
chronic ailments like this. And I think
True.
it's good to have at least the knowledge of all these
Yeah.
things, and also to knowing what you cannot do and who does that, so that it's good to send every. Sometimes I tell my patient, you go to him, he's better than me, he does this, and he's the right guy for this. And I think that's the best way of looking at it.
Absolutely. I mean, I think the way you guys do it, the combined approach of rehab, the quality
Yeah.
of life, the psychological aspects, we all give lip service, but to actually do it, and see it in action here, it's amazing.
No, the results are unbelievable,
Yeah.
and it's very motivating for
Yeah.
us.
It happened to me because I realized that what I was doing was not enough.
Yeah.
See, and I realized that being passionate of being a neurosurgeon from my 8th standard, I said, I have not become a neurosurgeon just to cut and remove
Yeah.
stitches. It's much beyond that. I want to
True.
get my patients back in their life, back on their feet, enjoying what's happening. Then I started seeing that surgery is only 25-30% of what I do. There's so much more beyond that. And the moment I added that, it became very fulfilling. Because then I realized that I'm having a holistic approach to that. And whatever fits in, you fit in well, because the goal is not surgery, the goal is getting them
Correct.
back to their life. I think.
I mean, more and more we are being invaded by corporate medicine, and people count how many procedures are you doing. I mean, I'm independent now. I was in a hospital, and they were not very aggressive about it, but more and more you see this.
True.
How many procedures are you doing? How many patients are you? Why is our MRI sitting quiet? Why is our OR not being used? And I wanted to go away from that. And yeah, when you need it, you have people like Dr. Sharan. You got people, you got technology coming out amazing technology coming down the drain that we can fix people. But I think at the end of the day, as a physician, what I went into medicine is to help people.
Absolutely.
And if they don't have to have surgery, and I tell my patients, I wouldn't, and they say, why don't you give me opioids? Why don't you do this surgery? I say, I wouldn't give it to my own family, so why would I give it to you?
Exactly.
And I think the approach, true multidisciplinary approach is the way to go.
I think so. I think that's very, and where every team member respects the other team member's skill sets
Correct.
and what he brings to the table.
Absolutely.
I think it's very important. And like you said, we are healers.
Yeah.
Eventually at the end of the day. And so I think that's something that we should never forget, that we are not working for any pharmaceutical company, or we are not working in any device company, or not working in an implant company. We are fundamentally focused on getting our patients' life better.
True.
Oh, that was an
That was-
exhaustive chat. I think we covered a lot of bases.
Yeah,
I think we had a lot of chat. I think every good thing has to come to an end, and I think we will have more chats for sure.
True.
And I'm hoping that this will be a motivation for you. There's a statement that Modi ji said in Guyana very recently, that you can take an Indian out of India, but you can't take India out of him.
Take an Indian out of India, but you cannot take India out of an Indian.
And one thing you've already done is you're in Indianapolis, so that you still have some India in you there. But I'm hoping through this podcast and what we have reconnected, I'm going to physically get you back into India so that I can use your skill sets
Yeah.
to serve the people of our nation, and which I think you would not say no to that. So you can come in your own aircraft if you want. Whatever you do, you do.
It'll
That'll
take
be
a
a
long
good
time
one.
with that small plane.
But eventually, I'm going to make sure that you are here and we can do something more revolutionary, affordable. The key is that, and if we can actually improve quality of life, I think you'll be fulfilled, we'll be fulfilled,
Absolutely.
and people around you to know that this is what it is, and can give back to the nation what is. So before we close, do you have any message or any do's and don'ts, any myths, anything that you want to tell our global audience, that so that they are like reassured, or they know that there's a method in this madness? What do you think? You have anything to say? I think you should say.
I mean, people think about chronic pain as a disease in my shoulder, in my knee, in my back, or something like that. I think it is a disease of your lifestyle. More and more you think about it,
Sure.
and I can do some cool stuff, and I enjoy doing it. I mean, I wish I just line up procedures and all the cool stuff I can do. But at the end of the day, I think if you sleep 8 hours a day, get some exercise for 30 minutes,
True.
and eat some reasonable food, half the pain will go away. Half the
I think so.
problems will
This
go
is
away. Yeah.
the cardiologist says the same thing, the neurologist
Neurologist.
says the same thing, the endocrinologist says
Yeah.
the same thing. So there must be something going
Yeah.
on here, because
Yeah.
the basic sattvic diet that we
Yeah.
have, I think it has its own role to play.
Absolutely.
True.
So
And don't hesitate to ask for help, and find somebody like you who really listens and understands. And I think what you mentioned is we should all, like you, have humility in our own ability.
Absolutely.
I mean, I've seen people get mad that, oh, you didn't get better, so somehow it's your fault. But you had an introspection to look at it and say, hey, what am I doing right? What am I doing wrong?
Sure.
And I wish more of us in the healthcare system do that. So,
And you didn't comment on relieving pain, restoring life. That what was on your mind when you made a statement like that?
I mean, at the end of the day, it's your life that's being affected. By hopefully reducing the intensity of the pain. People should go out, and I tell my patients, nothing makes me happier than you say, I don't need you anymore, doc. Or they come in and say,
True.
I went and did this. I went and played with my grandkids. I did.
True.
And that is the ultimate. It's not how many screws I put in, or how many leads I put in, how many
Absolutely.
procedures I did. It's people coming and saying, thank you, I'm doing better.
Absolutely.
So you have any last comments to make?
I think the holistic thing is what I have to tell everybody. There's a solution, definitely. There is a hope. And I think reach out to a specialist. A holistic approach is not wrong at all. Ask for help. You said that. I think you should ask for help. I think that's the message I want to give all our global viewers.
So guys, you see here, the psychologist is saying different things, but with the same end. The interventional neuro pain physician is saying the same thing with a different perspective. The functional neurosurgeon is saying the same thing from a different perspective.
Yep.
And all of us are saying that each of us individually is not enough.
Yeah.
We have to, as a team, and it's not the sum of the parts. It's actually, potentiates multifold.
Absolutely.
And as a group joining together is what makes the big difference. So I'm quite sure that there's so much more that we can talk on pain, and I promise you that we will come back with more such things, which is practical, on the ground, needed by people like you. But obviously, unless you subscribe to our channel, unless you share our videos, and hit the like button, and then the bell icon, and obviously comment. We will only do so much to reach out to people, because there's no point having all the skill sets, all the knowledge. He's sitting in Indianapolis, I'm sitting here, she's sitting wherever she is. And if we can't help the people, then we are doing a disservice to the whole thing, because we can only improve quality of life if more and more people get aware of what's happening. And that's the goal of this Rebooting the Brain podcast, to create awareness and education, all of you, to get you understanding what's going on. And don't
And I
forget
think
to
we would also love to listen to them. If do they want something else that they want to learn,
they can reach out
educate
to us.
themselves about, right? And if they can write it in the comment, that will be a good thing for us to
Yes,
take
yes,
this up
yes.
as the next episode. Probably we have enough experts around the world to get them and give them the information to educate.
We'll get the right people to come in and give you the right clarity on what needs to happen, and that's the only way we can collectively see. We'll be 2, 3, 4 of us can't change the world, but we can be the face of this movement that can make this world a better and more healthier place to be, with less suffering. So guys, we have Rebooting the Brain website, we have Rebooting the Brain book, we have Rebooting the Brain documentary. Look at any of these things. You don't know which of those places will give you something that creates hope for you, and that's what it is. And signing off for now from us, all of us here, thank you very much for watching. Jai Hind.
Thank you very much. Namaste.
Thank you.
And as a last customary thing, Vinayak, we always give a book to our, I know
I already
gave you a book. That was on the flight.
Yeah.
So that was a high-flying book. This is a grounded book. So, just as a, this one for completing the story, this is what it is.
Einstein, he is the person who has died.
Albert Einstein, guys. The same.
Albert
one and only.
Einstein died in April 18, 1955 in Princeton Hospital, New Jersey.
Okay.
When he died, before dying, he had a aortic aneurysm.
Okay.
He knew he has.
Okay.
Doctors, his friends said, we'll operate. He said, no, why do you operate? I
What?
don't want artificial life.
Ayyo.
I don't want artificial life. Left like that.
Ayyo.
Then it so happened that once naturally when it's not operated, it burst.
Correct.
It bursted and he died. When he died, the postmortem they did it, autopsy they did, and the pathology professor, Thomas Harvey, he took out the brain.
Of Einstein. Huh?
Einstein.
Whoa.
And Einstein before only told, before death, you don't bury my body. You should burn my body and take the ashes and put it in some river or somewhere,
Okay.
he told.
Like how our Hindu culture.
Then Thomas Harvey, he took permission from Einstein's son. I will take out the brain and we will study.
Okay.
Then he said yes. So he's taken the brain and he's moving about. When everybody knows that the Einstein's brain, priceless brain, only one he has taken, they chased him. He never wanted to give them. So he has gone. Then it so happened for 25 years, he is starting a bit of brain, giving it to neuroscience people who can study what is the organization of that, how, and other
Amazing.
things.
I didn't know.
They
this.
studied. I was in the house evening. One fellow came. And at that time, what Gaddafi did is, he left all the prisoners. Do what you want.
Ayyo.
War is there, no? You want to kill me? I will leave the prisoners. 1,000 prisoners in the all hardcore. He left in the city. You do whatever you want. पिस्टल गिस्टल है उसके पास एक आया मैं शाम में घर में उठे धड़ाल होके मारा दरवाजा टूट गया he came inside he said doctor मैं बोला सुनो आदा what is it he kept like this
to you
with the trigger on finger doctor anta ana Libby I am Libyan ma fish bait no house anta ajnabi you are foreigner anta bait fi
that means you have a house
house is there is it correct tomorrow I'll come you should go from here otherwise
sure.
Okay.
Amazing. Amazing. So what are the qualities of a good teacher, sir?
That's what I told him. First is make his mind to think. Giving facts is different. You should have a passion to learn. If you learn, you have got a passion, you will teach with that passion to the student. Student also will learn like that. Never insult a student at any time. And give him a free mind to ask question. If you do not know an answer, tell him I do not know. Tomorrow I will let you know. That should be an attitude. Here, student and a teacher, both are better. Both have learned.
Very true.
As long as you are under the same roof, teacher should be learned, student should be learned. Don't shout at a student when he asks a question. Don't ask. No, never do that. And create such an atmosphere that it should help in his growth and development. Atmosphere should be important.
Correct.
So these are some of the things one should keep in mind to be a good teacher. Probably people may be doing, or they must have forgotten, or they do it or not, we do not know. How do we know these things? But unless these things are there, it is very difficult to call a person acceptable teacher. I don't say good, better, best. That student has to tell, not I.
Correct.
I have to say I am being accepted by student community.
Correct.
There ends the matter.
Correct.
The rest of the adjectives we are not supposed to tell.
Correct.
They should do it.